Looks like most people kind of have their food procured and on its way. So we're going to get this party started tonight. Welcome to the 50th annual OSMS Conference, Dermatology and Primary and Specialty Medical Care 2025. I am Dr. Adam Tainter, MD, the president of this year's conference. The lecture and dinner tonight are sponsored by our OSMS partner, the Stewart Education Foundation. Please stand if you're associated with the Stewart Education Foundation. Do we have any here tonight? We'd like to thank them for all they've done. Thank you so much. I'm super excited to announce our speaker for tonight. Dr. Samuel Brown graduated summa cum laude from Harvard College in linguistics with a minor in Russian, then received his MD from Harvard Medical School, where he was a National Scholar and Massachusetts Medical Society Scholar. He completed internal medicine residency at Massachusetts General Hospital and a pulmonary critical care fellowship at the University of Utah. He is a research professor at Intermountain Health and the professor of medicine at University of Utah and cares for patients in the shock trauma ICU at Intermountain Medical Center. Dr. Brown uses clinical trials and advanced statistical techniques to understand and improve patient-centered outcomes from life-threatening injury and illness. As Vice President for Research of Intermountain Health, he oversees and supports a large research enterprise that focuses on serving patients, communities, and clinicians through the use and understanding of both cutting-edge technology, treatments, and treatments already in broad clinical history, with a particular emphasis on questions of embodiment, sickness, and death. He has published widely in medical ethics and history. On a personal note, Sam is one of the brightest and most insightful people that I know, and I look forward to hearing what he has to say for us tonight. So, thank you, Sam.
Thanks, it's good to be with you. Looking at the back, y'all able to hear me okay, or do I need to be a little louder? Be louder, it says. Okay, sounds like we're fighting some acoustics here. I want to talk about humanism in medicine. Wow, we're getting some weird muffling. See, are we doing okay now at this? Go higher, okay. We got some acoustic troubles, AV wizards, but I will go loud. Let's talk about humanism in medicine. The conflict statement is the standard one. I'm not being paid to shill for anything, although I'd be glad to shill for humanity. I was a linguistics major, as Adam indicated, and that influences some of how I approach topics, and it sometimes is worth pondering what we mean by the words we use when we're trying to have a philosophical conversation. And I think it's reasonable for us to wonder what we mean by human. But we'll start with, this is a picture of a French linguist named Saussure, and he's famous for arguing that to understand what a word means, you have to know what other words were options that you didn't choose when you chose that word. In other words, the context for a term is going to shape what that term means. And that's very important when we think about what human is. And human actually comes from the root of hummus, not the delicious tahini and garbanzo bean dish on the right, that's hummus, but humus meaning soil. The dirt of a forest floor still is called that, and that's what I've got on the left. And what it means to be human is to be dirty, specifically to be an earth dweller rather than a sky dweller. And that's why I put Michelangelo's Adam and God on the Sistine Chapel. Adam is the earth dweller, the being of dirt. God is the sky dweller, the being of air and planets. This is something that if we were training to be physicians anytime from about 2,000 years ago until about 300 years ago, we would have memorized it. It's the scale of nature, or the chain of being, and it's meant to be a taxonomy of every possible object or entity that exists in the world. And what you can see, I've drawn those little red dots. On the left is Adam, and on the right is Eve, and that represents all humans. And what you can see is these concentric circles. The circles outside of the humans are the planets and the angels, the celestial bodies, humans in the middle, and then below it there's all of the non-human existence on earth. So to be human is to be placed at the midpoint of this great scale of nature, in contradistinction to angels and celestial bodies and the gods, and in contradistinction to Fido and Sally. Sometimes when we say human, what we mean is not an animal. Sometimes, particularly when we're teenage boys ready to go to the movie theater, human means not alien. So there's a distinction. Anytime you say human, you are, of course, saying earth dweller or entity of the dirt, but you're also counterposing it to some other non-human thing. This matters a lot because humans have a capacity that, in one of the great ironies, is deeply human, to dehumanize other human beings, specifically by creating gradations within the human tribe, within the human species. And you'll notice there that the thermometer on the right has the most awesome degrees, because I asked Copilot to get me a non-copyrighted image of a thermometer. And you can see that one scale is C and the other is B, and that several of the numbers are repeated. We'll recur to AI, which is not, by the way, human, later on. But as we think about, do you ever have a distinction when you as a human are looking at another person that is in species Homo sapiens? Do you ever distinguish? And there the psychologists talk about infrahumanization. And just a show of hands, does anybody recognize those lovely little cartoon characters? This is a Dr. Seuss story that is beautiful. It's about the star-bellied Sneetches. There's a bunch of these vaguely emu, ostrich-looking beings that can talk. And along comes an entrepreneur, and he has basically a tattoo machine that will put a star on your stomach, charges $5 for it. As soon as all the rich people have the stars on their bellies, he says to the rest, well, I'll do it for 50 cents. Suddenly they all get stars on their bellies, and the people who paid top dollar for the stars on their bellies at first are pretty upset, and he comes to them and he says, well, I can do tattoo removal for $2. So they get him off, and all of a sudden it's prestigious to not have a star on your belly, and then so on and so forth, until finally he has taken all of the financial assets from the entire community, and they are utterly lost and confused, and no one can remember who started out with a star and who didn't. But what's very clear is that this desire to infrahumanize is ubiquitous among humans. When I was training in Boston, the classic joke was the best and fastest, most reliable way to get someone out of a coma is to walk up to their bed and say, I understand you're a Yankees fan. And notably, when you get with people who are on one of those polarities, there are stories that you tell about the other side of the polarity, something about their diminished cognitive capacity or their impaired ability to love, or perhaps they can't throw a ball in the correct direction with the correct velocity. But you feel like you know when you hear a marker something about them beyond who they are. I'm going to confess that I love my children and they love Harry Potter, and one's called Hufflepuff and somebody has doesn't have a nose, but what I understand is that there's the Hufflepuffs and the Slytherins, and they hate each other, and one is better or worse than the other. This is something that just goes around and around and around. When I was training, it was astonishing to me that there was this rivalry between Harvard and Hopkins, and Hopkins knew that the Harvard people were idiots who had rich parents, and the Harvard people thought that the Hopkins people were geeks who spent too much time studying math, and instantly they'd get into a room and you'd see them moving separately so that they could not be sullied by their contact with another person. And these ramify endlessly in our lives. There are always going to be markers that we use subtly to infrahumanize. This can get pretty severe. That flag is the Roma flag. Colloquially, they were previously called gypsies. It's an ancient Indian people that have been nomadic throughout Europe. The Roma were actually some of the people that were first gathered up by the National Socialists and were ultimately persecuted and exterminated. And it required that they be understood as less than human. And this can get pretty severe. You can see in the quote on the bottom there, this is an entry in a simple diary by a Nazi functionary who comments that on May 11th of 1942, they had a transport of 1,000 pieces of Jews, widgets, 1,000 parcels. So these living, breathing human beings were pieces of Jews. And they took them from the railroad station to the pit and they shot them. So this is the most extreme version of dehumanization. And as I've been indicating, that penchant to dehumanize is in fact, sadly, deeply human. When psychologists talk about humanization, what they tend to mean is a tendency to attribute a rich inner mental life to another person. The place I think it's easiest to see now is in the way some people interact with their domesticated animals. Domesticated animal does not, in fact, possess language, but many people that encounter them, I'm not disparaging it, I'm just describing it, many people in encountering them will attribute to that animal a rich inner mental life, emotions, motivations, reasons, and rationales. That's what it means to humanize. So people that are encountering their domesticated animals in that way are humanizing those animals. And contrarily, when we encounter someone and we assume that somebody from Hopkins doesn't have any social skills and doesn't know how to really solve problems, we are engaging in that dehumanization. But the psychologists at some level are dodging just a little bit. And I've been dodging it a little bit in these contrasts I've been talking about. What is it we mean when we say something's human? And this is my stab at it. I'll confess that I really, really love Gilgamesh. Gilgamesh is possibly, people argue, but possibly the oldest human major record. And it's a story of a godlike man named Gilgamesh who is deeply in love with his close friend Enkidu, who dies. And Gilgamesh then spends the rest of this epic trying to figure out whether he can get Enkidu out of hell so that they can be together again. And ultimately he realizes that there is no recovery from death. So from the earliest written records we as humans have been very worried about the fact that we die and have wondered frequently what we ought to do in response to it. But it's also true that we are awesome. And I don't mean this in the Independence Day, we fought off the aliens way, although by Jove, we would fight off the aliens if they invaded. I mean that humans have this capacity to love and wonder and feel and ponder and be that is in fact glorious and is worth our admiration and even adoration. There's something also important to understand that we sometimes miss in some of the rhetoric that we use, and that's that humans only really exist in communities. We actually do have examples of humans who do not exist in communities, and that's a group of severely abused children that are termed often in the literature feral children. Those are individuals that are deprived of all human contact for all of their formative years. And what we know from these terrible survivors and victims of this terrible abuse is that they are deeply, deeply autistic, deeply, deeply unable to function in any kind of normal human way. I'm not suggesting that they're not human. I am saying that the abusers have deprived them of one of the key attributes that we share as human beings. So to me, these are very important things. This capacity to love and wonder and think, the reality that we only exist really and truly in communities, and the fact that we are worried about the fact that we will die. Now, often we think in terms of medical humanism, and that's, we're here as medics of various descriptions. And I've wondered often what people mean by medical humanism. And here I've given a list of a few possible explanations for what people mean. I think often it's that fourth bullet point, what we mean by medical humanism is being ethical, being decent people. But sometimes it's as simple as who's got the 4.9 on the Google patient satisfaction scores as a mark of being a good medical humanist, and it may be, I don't know. As an ICU doc, they don't really rate us. They don't even actually know our names or even know whether we exist or not, because very frequently they're battling with encephalopathy when we encounter them. Sometimes we mean it's resisting the crush of bureaucracy. Some people use medical humanism as just a convenient way to talk about secular humanism, and it's a way to talk about deeply held, functionally religious views without having to get in trouble in these controversies about religion. I tend to take a somewhat pragmatic view. And to me, medical humanism, again, drawing on our reality as humans and drawing on the psychological understandings of humanization, is to treat patients as our moral peers. They have the same moral validity as we do. They have at some deep level the same priority that we do. And so for me, when I hear all the talk about medical humanism, what I hear is that we ought to and are called to treat the people we see professionally as our moral peers. Adam asked me to reflect on the fact that I work in this space and also have some personal experience with some of these weighty topics. And it's been almost 3 years since she died, but let's tell this story because I think it's very important. That's my late wife, Kate Holbrook, back in 2012. She was running and speaking at a conference actually at the University of Utah and noticed that her eye was a little bit blurry, but it was a really important conference that she had put together, and she just wanted to make sure it was done successfully, so she didn't bother to do anything about it. But Monday morning, she went in and saw her ophthalmologist, who said, "You've got a retinal detachment. Let me send you to a retina specialist." And the retina specialist said, yes, you do have a retinal detachment, but the reason it's detached is there's a tumor that has lifted it off the back of your eye. She lost her eye in a nucleation, and we started about a decade of living in the shadow of cancer. The first phase is the period of adaptation and equilibration before the tumor had metastasized. We actually had about 4 years where we just had 6 monthly scans. But what we saw through a variety of complications of the original eye removal and the difficulty of suddenly losing an eye and suddenly losing your confidence at the age of 40 that you would raise your kids to adulthood and be a grandparent was disrupted. There was, and I don't mean to pick on the house staff, there were other house staff that were marvelous, but there was one particular fellow in oculoplastics that did two things particularly that haunted me and induced a moral crisis. The first was, as we were working through post-op, and the first two surgeries actually failed, and they ultimately had to take a graft from her buccal mucosa to seal the eye over the prosthesis. She was in a lot of pain and was very nauseated by the pain in her eye. And in order to do his exam with no warning, he grabbed her forehead and gouged with his thumb so that he could get a good look at the suture line. And she burst into tears and reeled and almost passed out from the nausea. No warning, clumsy. He was just working really hard, had no attention except for him getting a good view of the wound to know whether it had dehisced, and not even a moment of acknowledgement of what had happened to her. The second thing was, as she was recovering from that final surgery with the graft, they'd had to put her case off throughout the day, and I know Bill Hamilton of anesthesia is there, and I think he's probably seen this, that people who are fasted forever and then get a big old whack of gas, sometimes they get pretty atelectatic, and they can be hypoxemic for a period of time after. So surgery doesn't end until 9 p.m. She's profoundly hypoxemic, and it moves on toward 1 a.m., and the PACU nurse is kind of done, and she calls him up on the speakerphone, and his answer is, her husband's a pulmonologist. He can take care of it. And so I called my friends, and I got a pulse oximeter, and I got oxygen, and I said a word that rhymes with duck and you, and I did it. But I set a timer, and every 30 minutes I woke up and I checked her oximetry through the night. So those two events from this one oculoplastics fellow, and I do not know his name, so I cannot say it, and I wouldn't anyway because I'm not that petty, caused me to wonder as an ICU physician, how many people have I treated the way this man treated my wife? And I realized dozens, if not hundreds. I was so busy saving lives that it hadn't occurred to me that there were people I was mistreating as I went about my work as an intensivist. And as a result, I and colleagues founded Intermountain Health Center for Humanizing Critical Care, and I wrote a book and published it with a university press that's a manifesto for reform in the way we do intensive care. That brought great meaning to my work and career and was deeply influenced by the experience we had as a patient and her husband. Phase 2 was hard in a different way. Phase 2 was metastatic, stage 4. Recurred in her liver, initially the size of a dime. Ultimately took over about half of her liver and took her life through peritoneal metastasis, a heavy burden that ultimately caused her to starve to death. That was hard. It was legitimately hard. And there were moments of grace in the midst of it. And here, as I was preparing for this talk and adding a couple of photos, I remembered that shortly before she died, we realized that we made it to 24 years of marriage, but it was extremely unlikely we would make it to 25. And she hated the idea of living funerals. We've had some friends and acquaintances who have done them, a kind of party before a person goes on hospice, such that they can be present for them. My experience has been about half of people kind of love it, and about half of people are like Kate and really hate the idea. But she was willing to do an anniversary party. So I don't know whether you can read on the left, but it says, celebrating 25-ish years of Kate and Sam. And we gathered friends and family. We carried a daybed down to it's called the Edge Hill Pavilion in Sugar House area in Salt Lake City. And it was hot and she was very weak. So we carried her down and we carried one of those portable air conditioners, those things that look like a small refrigerator and have the pipe out the back. And so we set that portable air conditioner next to her, blowing cold air across her as we had this party. That period became overwhelming and meant that I had much less time for the many activities that I've historically done in my profession, which meant that I narrowed rather a lot and focused on her and the kids and living. That does inform what I think about these questions, and I think you'll see, particularly as we get toward the end, that it has some relevance to some of the philosophical questions we're going to answer. So that's the personal history that frames it, but there's also general history. Here again, you see that scale of nature. What was great about the scale of nature is that you automatically had a place. You didn't have to justify your existence. You were dead center. You were between all the fancy celestial things in the skies and everything that was animal and vegetable and mineral on the earth. The nuance is that that hierarchy was ported over to human society. And as a consequence, you have this guy that looks pretty stoned on opium, but is some king, and he's exercising the divine right of kings. So God is shining the celestial flashlight on him, and merely by token of him being born to a king, he is now a king. And contrarily, people were born to be slaves. You might have heard the word serf. Serf is just a euphemism for slave. According to the scale of nature and the chain of being as it was understood, that really was the dominant understanding from Aristotle until 1800, 1850 AD, you were just born into a particular lot in life. The advantage to it is society was pretty harmonious, clear, clean, straightforward, and you didn't have to justify who you were. The disadvantage is if you're born wrong, you're a slave. So along comes this rather worried-looking gentleman, John Locke. He's not the only one, but he's kind of the famous one. And John Locke starts to make an argument that society should not be arranged on the basis of the great chain of being with its natural hierarchy and aristocracy, but that society should be built on the basis of the consent of all the people in the society. And he writes that it's our ability to consent as human beings that is our special uniqueness that motivates and justifies us. So that says you cannot be the king with a foot on my throat. You must build a society with me in collaboration. And you can see the American Revolution in the upper right and the French Revolution in the lower right. Those were both attempts, there were other influences of course, but those are both attempts to bring into being societies that are based on that notion that you must have the consent of the governed in order to rule. And that moves us closer and closer to the world we inhabit now. Other things are happening at the same time, but they have ultimately similar effects. Rural has become urban. And you can see, I got this from some German website, because I guess they're good at talking about agglomerationen. But what they're marking is that the vast majority of human beings until very recently lived in small communities, rural communities. And now the vast majority live not only in urban communities, but in these super urban megalopolis kind of cities like Sao Paulo or New York City or Shanghai. As a consequence, most of us spend most of our days in the company of strangers, relative strangers or entire strangers. And families are pretty small. Used to be that families were considered to be about 150, and that's not just talking about polygamists, and I honor their memory. The understanding of family, even independently of the Mormon polygamist experiment, is that it's not just the people, ma and pa, their few biological children, a white picket fence. It's people gathered together in the function of a household. So families were always an expansive understanding, now pretty small. And you can see, this is Kate and me during that phase one. We're up on the Empire State Building. And it's just two of us in a city of 9 million people that we do not know. And that is, to a certain extent, what's happening. The other piece that's really important is that there's a move. When you abandon aristocracy, you've got to have something to replace it. There's got to be some way to organize a society. You can't have perfect equality, even though many people honorably would want that to be the case. And meritocracy evolves. And what happens in meritocracy is that, on the one hand, you no longer have King Charles the 24th running things incompetently. You have people who are pretty skilled at it now running things. But the nuance is, you have to prove yourself. You don't automatically know who you are and that you are safe by token of who your parents and grandparents are. You now have to prove yourself. And Kate and I, back when we were starting our family, were dorm parents. In Harvard speak, they're called resident tutors, but we were just dorm parents. And what was striking to us, and in fact our Amelia, who's here today, our oldest, our Amelia spent her first 4 years of life there. And one of the reasons we left is as we were trying to nurture these children, we realized that the vast majority of them were in a constant crisis of their own moral worth. Because of the relentless nature of the meritocracy, they never knew whether they were good enough. They were constantly haunted by that. And that's not something that constantly haunted people before the rise of the meritocracy. So as a consequence, we have an image of modern humans now, and modern humans following Locke and others, they're in charge of their own fate. That Invictus, I am the captain of my ship and the something of my soul. I don't love the poem, but people do, and I honor that. But that's that self-determining individual thing. I'm in charge of myself, and if I'm not in charge of myself, there's something morally wrong with me. Increasingly, we're less clear about whether we think institutions ought to matter. We're very worried about being dependent on other people and each other, and we're constantly at risk of washing out of the meritocracy. What's notable is that illness threatens every axis of modern human identity. Illness threatens every axis of modern human identity. And at the same time, you have what some critics have called the medical industrial complex, which is really cool and really risky. The kinds of things that we can do, I mean, Mohs surgery seems like maybe a minor thing for dermatologists, but the fact that you can do that at all is phenomenal and fascinating. And you have to have a certain amount of high technology and financing to make it possible, to run the life support systems that we run, to do the valves that the structural cardiologists do these fancy new chemotherapies. None of that can be done without a certain amount of industrialization. But the worry is that as we industrialize, as we mobilize capital to be able to do highly technical things, we end up with a medical system that is characterized by some critics as a soulless, anonymous, wasteful, and inefficient medical factory. Illness threatens every axis of modern identity, and the medical industrial complex similarly threatens us as individuals. Which brings us into the pregnant questions surrounding dehumanization in a medical context. There's frank dehumanization. Frank dehumanization, that's a quote from interviews with some house staff who admitted that a woman was dying on their service, and when they talked about her, they said, "She's a big baby. She doesn't stop asking for this, that, and the other thing." The picture many of you will recognize is from the Tuskegee syphilis experiment, where poor black men were left to die despite adequate treatment being available for their syphilis, because scientists wondered what happens if you die of untreated syphilis. Those are, I hope, things none of us in this room has ever done, but I bet many of us in this room have observed at least once. Those should be exceedingly rare, and in fact, they should really be never events in the language so common now. But then there's subtle stuff. The gallbladder, the cutaneous melanoma, the wrist. Sure, it's a metonymy, but it's also stripping a human of what it is to be human. Not knowing and using a patient's preferred name. My late wife was a Kate. Her mom was a Kathleen. Her legal name was Kathleen. She was a junior. I guess they didn't call them that when it was a female junior back then, but it had been a critical part of her identity for her whole life that she was Kate, not Kathleen. 85% of the time that we were in a waiting room, someone would stagger out and say, "Kathleen? Kathleen?" Not Dr. Holbrook, which she was, not Kate, which she preferred to be, but Kathleen, that she spent her whole life not wanting to be. It's not that she didn't love her mom. She just wanted to be different from her mom, right? We can identify with that. So not bothering to know or use a patient's preferred name is a kind of subtle deconstruction of who they are. One of the things that struck me the most, we set up these patient family advisory councils as part of that Center for Humanizing Critical Care, and we had ICU survivors come in to tell us their stories to help us learn better. And I heard a story of a 30-something single woman who was very modest about her body, had not had any sexual partners, and was very religiously traditional and did not want her body to be exposed. And she had received a liver transplant. And 10 doctors walked in while she was awake on post-op day, I think it was 2, grabbed her gown by the bottom hem with no advance notice and flipped it up so that she was exposed genitalia to breasts. And she said that the hardest thing of her entire end-stage liver disease and her orthotropic liver transplant was that. And I thought, holy crap, I've done that hundreds of times because I'm an ICU doc. And maybe you got Fournier's gangrene and I got to go take a look. That is something you shouldn't do. And then the other thing I realized, again, out of conversations with patients, is that if you don't knock before you enter the patient's room, you're indicating that there's no need for me to signal that I'm coming into your private space. When a patient's in a hospital, their hospital room is functionally their bedroom. So when people walk into your bedroom unannounced, you either like the NRA and you have a gun and you shoot them, or you don't and you call 911, right? This is not a welcome gesture to walk in unannounced to a bedroom. And then the Johnny, it is called the Johnny. Where else? Sorry, I got my timing wrong. In fact, let's just recover that. That never happened. So in the modern healthcare system, you lose your clothing, and every one of you is wearing clothing. I noticed that. I'm very observant. I'm a scientist. And when you put your clothing on, you may not at the moment have decided, I need to send this particular message with this particular outfit. You may have. But over the course of the last years, you've chosen what you'll wear. And it's part of how you communicate to loved ones and strangers, this is who I am. When you walk into a hospital, you're stripped of that, and you're handed a uniform, and often you're referred to as a number. And now, you've never seen this before, but what other institution takes your clothes, replaces them with the nondescript uniform, and refers to you by a number? It's the prison system. There we go. See, that's perfect. Who says scientists can't use PowerPoint? And then there's another thing that sort of rubbed me the wrong way as I was working in the Center for Humanizing Critical Care, and that's the HCAP survey. Hospital Consumer Assessment of Healthcare Providers and Systems. And what's weird about that is that consumers are people you're trying to make money off of. Right? That's what a consumer is. You're not trying to be terrible to them, but you just want them to buy your thing. Please, can you buy my thing? That's what a consumer means. And a provider is somebody that's selling the thing that please, can you buy it? And so when we use the language of consumers and providers, even though there are plenty of people who feel strongly that's absolutely how we must speak, a part of me feels a twinge that I don't want to encounter the people as individuals that matter because I can get money from them. I want to encounter them as other human beings that I can be of use to. Now here I am a scientist, so I reviewed this literature pretty carefully, and there's a live question whether we need just a little bit of dehumanization, a kind of Goldilocks moment. There's decent data that dehumanization is intrinsically bad, that if people are exposed to dehumanization, they may begin to lose self-efficacy, and that may have negative health effects. There's also some evidence that when you dehumanize, you're more likely to provide inferior care. That's true. There's also some interesting evidence that goes the other way, although if you stick with the headline, you'll never actually realize that. The title of the article is Power Increases Dehumanization. But when you actually read the paper, what they did is they took medical students in England and they said they randomly selected them. Either they told them you are a house officer or you're an attending physician. So that was the experimental variable. Are you a senior physician or a junior one? And then they gave them a vignette. And the vignette was a patient needed a surgery that was painful. It would actually make their lives better in the long term, but it was painful and a little bit scary. And then they asked them to advise the patient. The more senior ones, the ones who were told to think of themselves as more senior, recommended the surgery and helped people move forward with the surgery. The more junior ones equivocated and they weren't sure whether they could really get behind it. And then they asked them questions about how they had viewed the hypothetical patient they'd encountered. And the senior ones tended to see them a little bit more as a problem to solve and a little bit less as a living, breathing human being. So it's tricky. Title's not accurate. I mean, it is accurate, but it's incomplete, because power also meant the capacity to help people get through a hard thing. What about burnout? We talk a lot about burnout. I think these days, all of us have at some point used the B word to describe ourselves. Most commonly, what we mean by burnout is we're tired and we feel like there's too much bureaucracy. Burnout does have a formal psychological definition. Regardless of the definition that's used, there is some evidence, it's complicated evidence, but there's some evidence that if you have too vividly human a sense of a patient that you're taking care of, if something bad happens to them, there's a bad outcome, or they're not able to follow through on something you hope they would follow through on, that you may feel more burnout. That's a risk. And remember that burnout actually originates in the mental health counseling and substance use disorder treatment domains, where social workers and therapists gave their all taking care of people that were at a high risk for relapse. And ultimately they became hopeless because they identified so intensively with the people that they were taking care of, and they were not seeing the recovery that they hoped to. So there is a risk associated with full humanization. This is Rodin's The Thinker, and until I saw it, I think we were in Paris at the Rodin museum, or what do they call that? The Rodin Museum, I guess they call it that. I can't remember where the original is, but that was the first time that I saw that The Thinker is actually sitting in front of a mass of people. I always thought he was sitting alone in a field pondering deep philosophical truths. But Rodin, when he did The Thinker, he's actually trying to figure out who's going to heaven and who's going to hell. And the people behind him are the people who are being assigned to hell on the basis of his decisions. And that image struck me as relevantly similar to the chaos of a procedure gone wrong or of a high-risk procedure, in this case maybe endotracheal intubation. When you are endotracheally intubating somebody, when you are doing a Mohs surgery on someone, what they most need from you is your utmost attention to the technical requirements of the procedure in front of you. So there are moments when suddenly realizing how much they love lilacs will interfere with your ability to provide high-level technical care to a person. There are limits to what we're capable of doing. Now, I'm not proposing that we go then down dehumanization. What I'm proposing is that we be thoughtful about it. And I developed a practice some years ago in the ICU when I was moving to a procedure of saying, I'm about to ignore you. For the next 10 minutes, I need to be completely focused on this procedure. Once the procedure's done, I'm back with you. So that I knew I was having a moment where I would let their full humanity fade so that I could focus technically, with the full expectation that they would hand it right back to me at the end. That's an example of some of the ways we can make it through. Now, it is 2025, so AI solved this already, and isn't that great? And ChatGPT. This, for weeks, people kept telling me this, They would text me, they would talk about it in Zoom meetings, they would send me emails. This is an example of a headline from a paper that was published in JAMA Internal Medicine. And the headline is what everybody was thinking about. AI chatbots are more empathetic when they're answering patients. And you can see the distribution here, the response quality and the response empathy rating. The gray out on the right is the chatbot, and out on the right is better. So you can see clearly by independent external raters who did not know which of was it the chatbot or was it the doctor doing it, they clearly and consistently said these are better quality and they're more empathetic. I thought, I'm a scientist. Maybe I ought to read the paper. And I LOL'd. The physician responses that the chatbot was being compared to was Reddit. Like Reddit, right? You ask the question, is today Tuesday? And 34 people say, I really hope you will choke and die on your own saliva. So remember, the questions you get are driven by, the answers you get are driven by the questions you bring to bear. So yes, it turns out that a chatbot that's been programmed to be pleasant is more pleasant than Reddit. And that reminds us that for now, AI and generative AI and the large language models, I asked ChatGPT to get me an image that shows the limitations of AI, because AI is basically a toddler with a college student's vocabulary. And this is the best AI could give me. The first 10, I exaggerated, the first 4 images it gave me was a toddler standing in the middle of a crowd of college students. So anyway, we're at the point right now where the LLMs can do a few things, but mostly they're a toddler who happens to have a phenomenal vocabulary. The exception, I think, and here is where we need to be careful. My guess is that, well, I don't know. By show of hands, how many people use a digital scribing technology in their practice? And how many use a human scribing? And then the rest of you just don't write notes. I'm just kidding. So it's beginning to pick up. I work at Intermountain, and we've been working on the rollout of this digital scribing. We have a little window here where the digital scribes are going to be making us more efficient, to wit, less of our time clicking buttons in a computer. We've got a moment before the payers start to further drop reimbursements because they say you should be able to see somebody in 42 seconds because you have an AI helping you, where we actually can use the time we're saving by use of these digital scribes to connect for a moment. But we'll have to remember, right? Because we get rapidly acclimated to whatever it is we have. So within just a few weeks of initiating a digital scribe, you're likely to feel just as harried as you were before because you've now filled the time. What I'd propose is that AI, if we're really thoughtful about it, can allow us to take those little extra moments and minutes that the digital scribes are saving for us and use them to connect just a little bit, to ask a couple of questions. So here I want to end on some thoughts about ways forward and some possibilities. And I love Utah, and I love winter sports, and I like the green, blue, and black safety designations for ski slopes. Green is total beginner, easy peasy, don't worry about it, you're not going to die, unless you're intoxicated maybe. Blue is a little bit of peril, but you got to work at it to really be truly maimed. Black is, yeah, brother, you could die. And double black is, man, okay, good luck, right? High risk for the double black, pretty easy on the green. And I tend to think about some of these approaches to questions of humanization in those terms. And I realized that dinner party rule kind of makes sense. Now, it burns a little bit more brightly and confusingly in the intensive care unit, but I think it's applicable in the operating room, in the pre-anesthesia area, and in an office. Functionally, imagine that you've been invited to a dinner party. And think about what your behavior would be like toward the host of the dinner party. Because fundamentally, patients are inviting us into their lives at a very vulnerable moment. Not always, sometimes it's something pretty simple, but even acne, for heaven's sake, is so severely stigmatized that people are coming to us with the very real possibility that they are disfigured in a way that makes them unpalatable as a potential life partner. So even something as mundane seeming as acne is freighted, is charged, is morally fraught for the people. So they're inviting us, and in fact, paying us handsomely to be a part of their lives at an important moment. Not terribly unlike a dinner party host. And there's just basic things that you do at a dinner party and things that you don't do. And I mean, if you've known them for 12 million years, fine, you walk into their house because it's the time. But in general, you knock before you walk into the house. You know their name, right? If we invite you to a dinner party, you don't walk in and say, Kathleen, right? You know who they are. You refer to them, right? You take the time to figure it out. You shake their hands. And then you notify a request before touching anyone, right? I mean, that's a little tricky because you do hug people occasionally at a dinner party, but let's say it's somebody you really admire and respect and you don't know them super well. You do now. Can I hug? And certainly, and here this is going to go off color, but it's not intended to be, you don't grab their private parts without permission, right? You just don't. So that's something that's pretty straightforward. And now, I don't think you're going to be doing a ton of work as dermatologists with individuals who are comatose, but if you do encounter them, know that there's reasonable data that between 3 and 7% of people that are ostensibly in coma are actually aware. Most of the time they're frightened. They're too afraid to open their eyes because they're having a delusional, hallucinatory living nightmare, but they are aware. And the other thing that I've noticed, this came to me, we went through, there are those spontaneous praise cards. Every hospital or clinic has a different name for them, but patients spontaneously praise one of the clinicians who helped take care of them. And we went through and we did an analysis of all of the spontaneous praise cards and what were the themes that were identified. And the most important theme that we identified for spontaneous praise for an ICU nurse was, they talked to my comatose loved one as if they could hear him. It hadn't necessarily occurred to me before, but there it was in black and white. That's what they valued the most. And so that talking to someone who's comatose as if they could hear, A, 3 to 7% of the time they actually can hear, and B, it again helps to humanize someone who otherwise seemed to be stripped of the signifiers of humanity. The other thing, I got interviewed by and in a big argument with a reporter from the Wall Street Journal for this paper, or for this article they did a while back. It was talking about the move toward more open visitation in the ICU. Used to be that anybody was forbidden to come to the ICU, it was considered dangerous, et cetera, et cetera. We opened the ICUs at Intermountain fully. It was always patient-centered. If the patient doesn't want you there, you don't belong there. But otherwise, come on in. COVID made a mess of so many things, including that. But we were able to identify, and there are randomized controlled trials that suggest that overall the benefit is pretty clear, that letting people in, the world experts in the humanity of the patient are the people they love and who love them, letting them in makes good sense. Another thing that occurred to us, and we published it, is that when you're putting in a central line, which can be pretty claustrophobic and nerve-wracking for the patient undergoing it, you actually, an anesthesia buddy showed me a comfort tent. You basically tape the dirty side of the drape up to an IV pole, and that allows air to move in and out and helps with claustrophobia. So an anesthesiologist showed me that. I was like, great, they're going to feel better. And then it occurred to me that that's a perfect place to stick their loved one so that they can talk to them, so that they can have someone they love looking into their eyes during a frightening procedure. So we switched over to that for central lines and published our experience with it. It works great. People are much less frightened. It really worked very well. It's a little bit blue. What we realized was some of the trainees felt nervous in that setting. So that's the trade-off. That's why I put a blue on it, because you need to work with the trainees carefully and explain what's going on. But I found that I much prefer having people in there. I screen them. If they're intoxicated, they need to leave. And if they faint, then I don't need them fainting. There was a terrible situation in California where a husband fainted during a delivery, had a traumatic subarachnoid off a countertop, and died. So like, damn. So I look to see are they intoxicated, and I ask them if they have ever fainted or if they have worries about blood. And then, of course, does the patient want them there, and do they want to be there? But once that's the case, bring them in. Here, as I was putting together a talk to give in Belgium, talking about our experience, I saw, and I've gotten their written permission to share their story and their images, I saw this patient that we'd had the privilege to take care of for months, and her husband, and she was out on her physical therapy rounds in the ICU. And what struck me was that he was walking with a cane, helping his wife do her physical therapy walkabout for the day. And I said, I'm wanting to communicate to the Europeans how important it is to have families involved in the recovery. And he said, okay, you can take this photo, but you always have to show it with one more photo, because the most important thing I do is I love her. And he paused and he gave her a big hug. That image is stuck. It still kind of clouds my eyes when I think about it. Because that's, if you let them talk and you listen, they have these great, great things to say and to help. Now here we're getting into blue to black, and that's around empathy. And that, I hope that strikes you as strange, because duh, we should totally be empathetic. The reality is that empathy is more complicated than we think. What commonly people have meant by empathy is a kind of emotional resonance. In other words, if someone is agitated, we should be agitated too. If someone is sad, we should be sad too. And Jody Halpern, who's this brilliant Berkeley now psychiatrist, wrote this book, From Detached Concern to Empathy, which I love. If you're interested in this topic, it's phenomenal. And she presents the book as solving a conundrum. There was a woman who was about to go on dialysis and had a good life expectancy on dialysis, a relatively young woman. Her husband cheated on her and abandoned her while she was in the hospital. And she became deeply depressed. And in that depressed state, she told the teams, I will not start dialysis. And the teams resonated with her sadness, they resonated with her nihilism, and they said, yeah, fine, you don't need to do dialysis. Jody Halpern's point, and as I recall, she actually manages to intervene and fix this a little bit, get her through the depression, let her see a life on the other side. But her argument is that the docs felt like they were being so empathetic because they were resonating with her sadness, rather than doing the work to imagine her world as it is and can be. Not in the sense of forcing her down a particular direction, but of trying to understand what are the things that are interfering with her ability to live and dream a life. And that brought me, and I think Jody Halpern actually talks about this, but if not, whatever, sue me. Or don't sue me. You guys won't sue me. Empathy actually is a fake word that was coined in the early 20th century by a German art critic. And empathy, he coined, to mean imagining yourself into a work of art, bringing your emotion into a work of art. And empathy then is this kind of curious concern and interest to understand another being. In art criticism, it starts out as a curiosity to understand a work of art. But I'd argue that for us, empathy is a genuine curiosity to understand the idea world of the other and to be ready to explore it with them. And the reason that I think empathy can be so tricky is brought to bear in this final topic. And that's around this notion of death with dignity. And I want to honor the variety of understandings, and I want to honor the variety of experiences with terminal illness. And I think it's important to remember that dignity is, in fact, an attribute of every human being. Homeless guy twerking on meth and shooting a gun into the air has every bit as much human dignity as Queen Elizabeth. We all have dignity. Now, respect is a question of whether we behave in a way that honors and acknowledges the inherent dignity of an individual. But the notion that death is not dignified if there is suffering associated with it, or if it does not occur as a result of the ingestion of a dose of secobarbital, seems to me to be just untrue on its face, and to be at high risk for a distortion called disability stigma. And here we'll close on an image from my own life. As Kate was looking at her last year of life, we all wondered, how much time do we have left with her? We had a middle daughter that was about to start school, college, older daughter that was about to start a Latter-day Saint mission. I was trying to figure out what I should be doing with certain job opportunities. We were just wondering. There were these scheduling questions. And they seemed sort of absurd in the face of a terminal illness. But on the other hand, we hoped we had plenty of time with her, and the point was to live. And one day, a few months before she died, she said, all this time y'all spend trying to figure out contingencies in your schedules based on how long I live make me think you want me to just hurry up and die. Nothing could have been further from the truth of our lived experience. We wanted her to live as many years as there were on any calendar ever printed. But we were busy surfacing the implications for our day-to-day lives of her progressive disability. And that really forced us to reconsider and to think much more carefully about the cues that we give to people who are vulnerable. Because people with a terminal illness and people with severe disability are exquisitely vulnerable. They're vulnerable to stories that say, you don't belong with us, you're a burden on us, maybe it's okay and better for you to be dead. I'm not trying to be partisan here, I'm not trying to be black and white where there are shades of gray. I'm trying to communicate that as I've spent these last about 13 years now, I've realized that a lot of the stuff I've thought about that model of just be nice and let them self-determine is based on certain fictions. It's not our job to self-determine for them, not at all. But it is our job to understand the messages that we send. And the message that we send when a person with a terminal illness says, should I kill myself? The message that we extend when we say, sure, have a secobarbital, is very different from a message that we send when we say, I love you. What adventures can we have today? And as we worked, as we leaned in, this is an image from that 25-ish anniversary party. In Kate's wrapping up time, we took her to Kenya. Her whole life since she was a little girl, she had wanted to go see Isaac Dinison's home and wanted to see where they filmed out of Africa and wanted to be a part of that story. So we took her to Kenya. We took her to the French Laundry. That's super weird and super specific, but it's this fantastic restaurant in Napa Valley that's helmed by an incredibly gracious man, Tom Keller. And we managed to kind of pull some strings and got dinner there. And it was a disaster. The cancer at that point had so choked her bowels that she couldn't have it. And she had to go early. And Keller came out and gave her a hug. And his staff came and took care of the kids. And we were able to say this was a really, really crappy thing made beautiful by patience and accommodation and curiosity. And then when she went on hospice, she and I are both kind of worker bees. That was the list of what we wanted to get done as she was entering hospice. And she actually clocked hours at work for her first 2 hours on hospice. And I found that as I was preparing for this talk, and Adam had said add a little bit of a personal detail, that we could have said, oh, your fate is so terrible. Oh, your fate is so terrible. If you need to kill yourself, go ahead. We'll honor that. And I'm aware that this is really hard and really hard for all of us. But instead, with her guidance, we said, what adventure can we have today? And we were ready, when the adventures didn't go as planned, to keep looking for adventure. So, that's kind of a sad place to end. Being human is being sad, but it's also being astonished and being happy and being connected and being curious. And I hope my message to you can be that there are spaces and ways and places for all of us, no matter where we are, what we're doing, to have moments, even if it's only one patient per day, to have moments where we see that deep humanity in each other. Thank you.
Thank you so much, Sam. Does anyone have any questions for Dr. Brown? As I was hearing him talk, I was talking to my wife. I really like watching sports movies. Okay, I am not a sporty person, right? I don't play football. I don't play basketball. And I realized as I hear Sam talk about his experience, I don't think I can think the way he does, but I love hearing what he has to share. And thank you for sharing it with Sam. Thank you so much. I hope that makes sense because that makes sense to me. But any questions we have for Dr. Brown? Please, there's some microphones.
My concern is that the nurses are so burned out, everybody's so burned out, and everybody's so tight on time, they don't have time to sit and talk and listen and hold people's hands. And I don't know, when is that ever going to change? I just seen it from the time, 40 years that I've been, doing this, that, we used to sit with our patients and really spend time with them and get their story. Now, everybody's like burning the candle at both ends just to get through the shift and to do all their paperwork. I don't know when that's ever going to change. Do you have any insight on that?
Yeah, what is it to move into sports? Yogi Berra said prediction is hard, especially about the future. So you had two questions. The first question I don't know. People keep saying that the digital scribes are going to solve it so that we can just really have a lovely moment together with somebody and the scribe will sort it out and it'll all be good. I worry that once that technology fully works, they're just going to double the patient visits per half day of clinic. So I do worry about that. But the second question is, how do you maintain the human connection when you're exhausted and when things are so harried? And there's a nuance here. We have so much language in contemporary culture about quote unquote authenticity. And the notion that if you practice something or if you deliberately try it, it's somehow inauthentic. I don't like the language of authenticity. My aspiration is to be deeply inauthentic. But let me explain what I mean. I want to be genuine and kind and better than I am prone to be by my nature. So when I say I want to be inauthentic, what I mean is I'm willing to work at doing something that doesn't come naturally to me. So here's an example. I have a daughter, my youngest daughter is a very bright kid who's had terrible psychiatric illness. And one of the blessings that's come from her time in psychiatric care is that she has this ear for complimenting and this eye for seeing. And so I watch her, and I've been copying her. When she sees someone, she says, "I love your earrings." How long did that take? Like a second? "I love your earrings." And then you move right along. So it's finding little moments. And again, the authenticity mafia will say, "Oh, you're practicing, you're just trying to be nice." As if there's a problem with being nice. But you want it to be born of genuine, right? It would be dangerous if you're being kind like that so that you can exploit someone. But if you're being kind like that, because by God, you want at the end of a day to know that you didn't just make some money for a health system and diagnose a couple of whatevers, you also lifted somebody's spirits, I think it's okay to practice it and to figure that kind of thing out. So you figure out what's most adjacent to your personality in the range of quickly gracious. And the other thing is you can really, we're docs, and docs, as a rule, push themselves pretty hard and are pretty self-critical. The reality is that we're not going to be the perfect kind doctor to every patient we see, and that's okay. But if we could get a couple of patients a day, every 10th patient, I think we start to see a capacity for it. And that little moment of eye contact and the little moment of curiosity, the little moment of compliment can work. Now, we do have to be mindful. There are people who spring out of the Wikipedia page on logorrhea. That's that kind of, people call it word vomit now, but I like logorrhea. There are people who, if you say, "I love your earrings," 23 minutes later and 400,000 syllables later, they take a breath, right? Remember though, A, they're honorable humans too, but B, they're pretty rare. I think some of us reflexively don't ask questions or don't say kind things because we're afraid it's going to be a 10-minute story we can't extricate ourselves from. But the reality is that's like 1% of the people you encounter. And you can ultimately, there are ways you can practice them too. I'm so glad you're telling me this story, and I worry a little bit about some of the other patients that are waiting, but thank you for telling me that story, right? And you have to interrupt them to do it. You figure out those things. But what I would recommend is in patients that you see longitudinally, carve out a little bit of time, because that's pretty natural to somebody that you see longitudinally, to have just a little bit. And even if you can put, one thing I put in my notes, and I'm not an outpatient doc, but sometimes patients stay in the ICU for months and months. I'll put in my little note, son Brad just graduated college. That's just in my note. That's part of it. So then when you see that prayer note, you remember, how's Brad? They're stunned, their humanity is acknowledged. And then for just the people that are randomly there, just that little bit of kindness. And you figure out what feels genuine from you. But there's so many cool things about so many people. I don't know whether that's helpful. But that's what I've been working on. And I found that it lightens things just a little bit. Thanks.
Sam, I really love your glasses.
Thank you.
Start out like that.
Do you want the TMI story behind it?
If you want to share.
As she was dying, Kate turned to the godmother of our oldest child, and she said, "When I'm gone, can you please dress Sam?" So Susan chose these glasses for me.
Thank you also for your presentation. Thank you for sharing your very personal story and Kate's story. I appreciated your comments about the AI scribes. My employer is not inclined yet to provide me an AI or a live scribe, although I was fortunate to be part of a 12-week crossover pilot study evaluating a couple different products that the institution was considering purchasing. And my experience with that surprised me in one way that I guess in retrospect I perhaps ought to have anticipated. I had hoped that having an AI scribe would alleviate some of my burnout by enabling me to get my charting done faster, to get in the car sooner, to get home to my family sooner. And it did that. Both of the products did. And in fact, I found that I not only was getting in the car sooner at the end of the evening, but my charts were by and large closed, and a lot of my inbox volume had been addressed as well. But what I hadn't anticipated, and I perhaps ought to have, is that having the AI scribe fundamentally changed the nature of my interaction with my patient. I had arrived at a point in my career where, I often had 2 or 3 patients waiting for me, and I was running from one to the next. And there was a screen in the room between me and my patient, positioned in a way that I could sort of easily shift my glance from the screen to the patient. And I thought I was pretty good about looking at my patient and seeing my patient. But when I had an AI scribe, I didn't log into the computer at all. There was no chart review. There was no distraction at all. The patient had my deep, full attention. And I felt that, and they felt that. They told me that. And I got my charts done faster. And so, to the extent that I had hoped that it might alleviate my burnout to some extent, it did that in the sort of number crunching, clock management way. But it also alleviated my burnout by reconnecting me with that humanism. Part of why I went into this career in the first place. So I guess my question to you, and you had alluded to this in the prior question as well, and you had alluded to the medical industrial complex. It remains to be seen whether my institution is ultimately going to fork up the cash for any of these products. Although if they do, I fully anticipate that they're going to expect me to see some percentage more volume each day to pay for this product. And my deep concern there is that by adding more volume on, they will have undermined the whole opportunity that presents itself here, both in terms of getting me home to my family sooner and preventing me from leaving the organization and turnover and churn, but also the opportunity of what it's doing in that exam room, this sort of sacred doctor-patient relationship. What advice, if any, do you have for how I can enlighten my supervisor and my supervisor's supervisor's supervisor, the anonymous administrator who is dehumanized, right? Yeah. Who is him or herself dehumanized because I don't know who this person is who's controlling me like a puppet.
Yeah. There are some complex literatures that are probably relevant to this. fundamentally, the way you get big orgs to change is you change the regulatory environment or you make the labor market harder for them. So either there's a regulation that says that the patient connection scores need to be X or you lose reimbursement, or that say you need to drop the lifetime to documentation, you need to move the lifetime to documentation ratio above Y threshold. So that's one way to get change in these big orgs, is to have a regulatory hook. And the other is much more complicated, but fundamentally it's labor markets. And I think we're at this funky moment where there are not enough docs to go around, and there are decisions that have to be made. What kind of physician extension opportunities are there? And people are looking at not just the advanced practice clinicians, they're also looking at AI chatbots, right? I mean, better than Reddit. So they're looking at other modes of interacting in a team-based model, and it's this tricky nuance. At what point do they say, we don't really need the same density of physicians, such that physician bargaining power is eroded? If we're able to achieve a kind of happy middle ground where we are the supervisory expert consult QA supervisor role, then I think we retain the capacity to let the systems know, if you don't take care of patients in this way, we're going to go work somewhere else, right? What they respond to are regulatory burdens, patient flow, and labor market. And so either there has to be a way to communicate that we get more patients wanting their hips done at our institution if we behave in this way, or you communicate that you're going to lose your physician workforce realistically, or you figure out a way for it to be regulated. Because I'm now an administrator, like, the dehumanized administrator. Like, I still see patients, but not as much as I used to. And as I get to know the administrators, and I know best the ones at my org, the 99.5% of them are these honorable, decent people who are trying to do the right thing and are trying to deal with the fact that margins in nonprofit healthcare have fallen from 10% to 2%. And the margins in nonprofits are your ability to replace an old hospital, buy a new robot, these kind of capital expenditures. And so it's easy to be like, 10% margins, big jerks. Why are you doing that? But at a 10% margin, they invest in research, they invest in more charity care, they revamp the hospitals, they build a new hospital, et cetera. When you're at 2%, you're mostly just keeping the lights on. And so I think as they're navigating that, they're going to be receptive to those traditional three lines. The one wrinkle is if in fact there is a transition over to what my employer is calling proactive care, other people might call value-based care. When we focus group value-based care, they were like, you mean like buying something at Walmart instead of Target? Like, what do you mean by value-based care? So that's why Intermountain calls it proactive care. If you can demonstrate to them that having that connection with a patient increases the patient's self-efficacy such that they're able to be higher, better outcome participants, collaborators in their health outcomes, then I think you've got, I think you've got a line to follow with them. But otherwise, you really are stuck with either you threaten their labor market by just saying, we've all talked and we're going to go work for someone else if you don't solve it. Or I don't know what is going to happen for the next few years in regulation of medicine, but figure out a regulatory framework or figure out a referral pattern. Yeah.
Earlier on, you were talking about a scenario where you were having to help a patient decide whether to, continue or to pass away with medicine.
Right.
I mean, oftentimes we run into scenarios not exactly like that, but where we're trying to anticipate or understand where our patients are coming from.
Right.
And it's very easy. I've fallen into the trap of making assumptions about what my patients value. So my question for you is do you have any kind of ways you get patients to open up to help you express their values? Are there certain questions you ask or certain things you do to help understand where they're coming from?
Yeah. I come at it from the side that I showed up for the ICU one night and my sign out from my colleagues was, hey, sorry to dump this on you, but the daughter can't come until 7. Can you do a family meeting? Family is nuts and they will not stop and we don't even know what to do anymore. And I said, okay, sure, I'm ready. And I went in and I read about him to be ready medically. And then when she came in and sat down, my first sentence was, tell me about Bob. And she paused and then she burst into tears. She said, I've been here for 2 weeks. You're the first person who's asked me about my dad as a person. And my thought was, I know the medical piece, but I don't know him. And what we're looking for is a merger between medical and him. So I try to start with non-medical curiosity. And to your point from earlier, you cannot have this conversation with all your patients. It is going to be something that's going to slow down that day. So you do try to be thoughtful. Who is at high risk for an outcome that they would be surprised by and not feel was true to them as a person? And those are the times to sort of ponder it a little bit. And then I start with, hey, just tell me what you love. What are your favorite things? Tell me about your favorite people. And it sounds like it's going to be 45 minutes. Rarely is it. Usually it's more in the 5 to 8 to 10 minute range. But that sort of opens them up. And then the next thing I ask is, tell me what phase of life you feel like you're in. Are you right in the thick of things, in the middle of it? Are you sort of halfway to the last chapter of the book of your life? Or are you in the last chapter of your life? Because that, honestly, I actually did a fair bit of research on this back in the day. Overwhelmingly, what defines people's sensibilities about wrapping up is the phase of life they understood themselves to be in before whatever acute setback it was. And then if somebody tells you that they feel like they're in the last chapter of their life, that's somebody who would be really interested to know that you feel like whatever problem you're treating has a 50% likelihood of sending them into the next life in the next 6 months. For somebody who's just in the middle of life or just starting out, I actually asked, I didn't publish it because I got distracted, and it was sort of informal, but I just started asking friends and neighbors if being tortured for 6 months would save your life, what probability of success would you require before you'd submit to the torture? Because that functionally in an ICU, that's what we're talking about, right? You're pretty beat up for 6 months before you get better on the other side. And when I asked docs, their answers were between 30 and 70%. I have to have a 30 to 70% probability of survival before I'll let you torture me. When I talk to lay people, their answers were somewhere between 1 in 100 and 1 in a million chance of survival. So for people who are not already understanding themselves to be at the end of life, they want to soldier on in the vast majority of circumstances. If you think they're soldiering on against a 90% probability that they're going to die, then I'll ask about, I'll use the framing of, well, let's hope for the best. And that's that 10% outcome that we're hoping for. And we're fully there with you. And let's prepare for the worst. If things don't go the way we want them to, is there anything we will regret not having done? And let's do that. And then, simultaneously, it affirms their desires to soldier on, and it helps them do whatever wrapping up they need to do, such that the feeling that things left undone or unsaid won't hold them back when it is ultimately time to depart this life. So those are some of the approaches I take. But also recognize that, so last story, in Kate's last 9 months of life, there was a constant harangue from well-intended medical professionals to hurry up and get her on hospice. And in those last 6 months, she finished another book. She went to Paris. She went to the French Laundry. She helped get a kid home from residential treatment. And we finally just had to say, when somebody looked like they were going to have that noble conversation with us, telling us yet again to hurry up and put her on hospice, we just would meet them and say, oh, she just needs to finish her book. And then they're like, oh, okay. If you got a book to finish, we'll lay off a little bit. So just be mindful that sometimes our best intentions are quite violative, because they become a kind of steady drumbeat of you don't belong here. So those are my thoughts on that topic.
One more question, Kurt. Thank you.
Yeah, just really quickly, I appreciate you being here, and I really appreciate the personal story that you've brought to this conference. So thank you very much.
Thanks.
I've been fortunate enough to practice in the same practice for almost 3 decades and develop relationships with patients all that time. Early on in my career, there was a societal tradition that brought humanity home to me, and I think it's something that's being lost, and I'm not sure how what you're teaching us now is taught to the upcoming clinicians, but the obituary. For me to take care of a patient and then read their obituary and learn things about them that I never knew, even though my encounters were brief, 15 minutes, 20 minutes, but to learn how deep and rich their lives were and to never realize that as being their caretaker really hit home with me the humanistic part of medicine. And I just throw that out there, and maybe you have a comment on again, that's the obituary is going away, and I don't know what's going to replace that in some young physician's career to help bring that home. But I do appreciate what you're bringing to us tonight. Thank you.
Yeah, thanks. I also like to read obituaries, and for a patient that we've really connected with, I like to go to the funeral as well and celebrate them. You have to be thoughtful. You can't go to, in an ICU setting, 15% of your patients die, so you can't go to a funeral every day, but being thoughtful. The one cautionary tale, there's a French randomized controlled trial that had the totally opposite effect that we all anticipated, and it was run in France. They're a much more hierarchical society than ours. Great food, but very hierarchical. So there's a vast chasm between doctor and patient in France that's much vaster than it is in the United States. But this great guy in Paris, Elie Azoulay, has been working on this for a long time. And the broader group does a randomized controlled trial of condolence letters. When a patient dies in the ICU attending that was most responsible for their care writes a brief condolence letter. And honestly, before the RCT was published, I would do that. I would write a condolence letter. There's actually in Annals of Internal Medicine about 20 years ago, there's a piece about writing the condolence note. It was internists talking to internists. The RCT showed that those who got a condolence letter from the ICU physician had more PTSD, anxiety, and depression than those who did not. And it wasn't until a year later that they did a qualitative analysis that I think we in the field understood what was going on. The qualitative analysis was understanding what were the reactions to it, and the reactions to the condolence letter were propositions for dates, coming back to the physician, which was weird, but really the tip of a broader iceberg of believing that a relationship was intended to be created, and then realizing that there was in fact no relationship. So in France at least, that first kind note from the doctor was so unanticipated that it raised expectations that there was a deeply personal ongoing connection, and that was not true. And my sense is that that probably is what was driving it. So after that, I started doing condolence letters only in settings where we had a real connection and bond, and where I would be happy to take a call in the future. Whereas previously I'd try to do it just generally. But it's, the students that are coming up are different than we are, and they have some real strengths where we were weak, and they have some weaknesses where we were strong, just as all humans do. One thing that they have been better about is these moments of silence or acknowledgement, or, you could imagine the practice when you hear that someone's died, just at whatever huddle you have or whatever time you are together, just say, hey, I'd love just 30 seconds of silence for this person, or remembering that. But I think it's a bummer that fewer and fewer people are doing obituaries. I think those are important, so thanks for that.
Thank you much. We're our own bus people today, so if you could clear your plates, put them in the garbage on your way out, that would be awesome. Look forward to seeing you all tomorrow morning. Thank you so much.
2, 2, 2, 2. Hey, hey, hey. 2, 2, 2. Hey, hey, check. 2, 2, 2. Hey, 2. Hey, 2, 2, 2. Hey, 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 check. Check 2. Hey, hey, check, check 2, 2, 2, 2. Hey, hey, 2, 2, 2. Hey, check, check 2, 2. Hey, 2, 2. Three, 3, 3, 3. Hey, hey, 3, 3, 3. Hey, check 3, 3. Hey, check 3, 3, 3, 3, 3, 3.